are live. We are live. And this is Senate Health and Welfare. We're back. And we're looking at three different bills that we have spent some time, a little bit of time on. I think sufficient. But H611, Jen, why don't we start with that one? And I know that Medicaid, I think Alex McCracken is also up on the screen with us. Alex, are you there?
This is joining right now.
Oh, he's joining. She joined. That's good. All right. So why don't
For the documents to.
Yep, I'm on right now.
yes. Okay. Okay. Jen, why don't you just describe to us what we'll be looking at?
All right. Well, I will update this one first. So there are two. Oh, Jen Carvey, Office of the Legislative Council.
That's the first.
There are two different documents that are getting posted. One of them is an amendment that includes the things that I think the committee had talked about definitely wanting to do. And then there's a standalone one on the HIV PrEP language, because I think there was still some question about, did you want to move forward with that? If so, was Medicaid in or out? So I have that as a standalone. So I'm just putting up the Word version now while it gets loaded on your committee
Can you
page.
make it into any of that big? Sure. Okay. Thank you.
So this it's not a strike all amendment because there were just two amendments. And only one of them was actually, I guess they're both things strike bill. So the first one is striking out section 2 and putting it back in with an addition to it. So section 2 is the language on 340B entities. And if you remember, you were striking this language here prohibiting the discount from being done as a rebate instead of a discount. That's still happening, but I've added back in this language that was requested by state and perhaps others, that says under current law, and I'm changing, a manufacturer, this is a prescription drug manufacturer, or its agent shall not directly or indirectly require a 340B covered entity to submit any claims, utilization, encounter, purchase, or other data as a condition for allowing the acquisition of a 340B drug by or delivery of 340B drug to a 340B contract pharmacy, and this adds, or a 340B covered entity, unless the claims or utilization data sharing is required by the feds. So this is really just to add in here 340B covered entity. My understanding of the reason this language was not in previously is that there had not been any issues with the manufacturer or its agent requiring the 340B covered entity to submit claims in order to receive the drug itself. It sounds like there may have been some changes in that area that are creating issues. So this would specify that cannot be a requirement for allowing acquisition of the drug by a contract pharmacy or the entity itself.
Got it.
And then continuing to strike the language in D. And then the second instance of amendment is in section 9, which is the effective date for the Medicaid coverage of doula services. We've had the change, you've made a change to delay the date to 2007, but we hadn't made the corresponding changes to OPR and the rulemaking and when the rules will be effective. So we're striking out 2026 both times it appears, and we can look at what that is in context. And inserting in lieu thereof, strike through 26, adding in 27.
Okay. And then we have
a separate talk. One. So this was my take on how to codify the HIV prevention drug language should you choose to put it in. So it's formatted so you could put it in, but also you don't have to. If you did, strike out the effective date section and put in 3 new sections. So the first one, I would add this in the existing statutory section on reproductive health care services, starting out with the definition of HIV prevention drug. meaning any pre-exposure prophylaxis drug or post-exposure prophylaxis drug, including oral and long-acting injectable formulations that is approved by the FDA, and FDA is already spelled out and then put in parentheses earlier in this existing section 47.7, that is approved by the FDA for HIV prevention, or that is otherwise authorized for HIV prevention pursuant to FDA labeling or federal clinical guidelines. We didn't need a definition of health insurance plan because this is going into the existing subchapter, chapter on health insurance plans and the existing subchapter on benefit requirements, coverage requirements. So this would require a health insurance plan to provide coverage for HIV prevention drugs without any deductible, co-insurance, co-payment, or other cost sharing requirement, and without imposing prior authorization or step therapy requirements, quantity or frequency limits, or any other protocol that may restrict or delay the dispensing of any HIV prevention drug. The coverage would include patient education and counseling by the covered individual's healthcare provider regarding the appropriate use of the HIV prevention drug or drugs prescribed. And then this language, if you're choosing to include Medicaid, we would need to specify the subsection shall apply to Medicaid and any other public healthcare assistance program offered or administered by the state or by any subdivision or instrumentality of the state. Then would add a section 11 on clinical pharmacy and prescribing that would add to the list of what pharmacists may prescribe in accordance with a state protocol approved by the Commissioner of Health, and adding in for patients 18 years of age or older, medications for the prevention of HIV, including those for pre-exposure and post-exposure prophylaxis. This language, I think I mentioned in this committee, is also being looked at and I believe added to the OPR bill down the hall.
GovOps.
Yes, in GovOps.
Oh, it's still in there.
And
I don't know. Can you help me with that? How's that gonna play out?
so it,
If they're the same.
yep, so if that's why Tim and I keep in touch to make sure we're using the same language. I think the OPR bill is actually adding another 14 or doing some other renumbering here.
Yep.
So when we do our statutory revision work in the summer and make sure that everything that you have enacted in this 2026 legislative session gets properly incorporated into the statute books, we would kind of harmonize those together and maybe put a little note if one of them was enacted as, say, subdivision 13 and one was enacted as 14, we could put it in where it fit and put a little note saying, explaining the change. But it would know that it was enacted in two places. And then for effective dates, the underlying act, I believe, was taking effect on July 1st, 2026. So I kept that, except that the section 2, which is the 340B language, I had take effect on passage along with this one. So we may want to make that same change in the, if you don't put this in the amendment. And then I had the insurance coverage requirement roll out over the course of the year, as we typically do with insurance coverage requirements. So it take effect on January 1st, 2027 at the beginning of the plan year, or most plans plan year, and apply to all plans issued on and after that date when they are issued, offered, or renewed, but in no event later than January 1st, 2048.
Okay, questions for Jen?
So that is what I believe would be necessary if you wanted to include this language.
I've got two questions. Well, actually, Jim may or may not be able to answer this, but I'm just curious as to why we decided that there's no copay required here.
That was the proposal. So I've just carried forward what was in the proposal from the advocates. But yes, that's certainly a policy question. I think the HIV, the pre-exposure HIV prophylaxis medications, I believe are currently required to be provided under federal law with no cost sharing. So really that, so it would be, it would be codifying that at the state level and then also applying the same parameters to the post-exposure.
You know? Mine was, I thought the discussion at the time, Jen, was PrEP was covered by Medicaid. PrEP may not, have been covered by Medicaid?
I think this is why you're gonna hear from Alex at DEVA.
We're gonna have Diva testify right now.
Oh.
May answer your question.
All right.
Okay, so Alex, are you there?
Yeah,
Yes, I am. Hi, good morning,
morning.
Madam Chair, members of the committee. I apologize for being off camera. I am quite sick and my face is not ready for the public record at the moment. To answer the question, we do cover PrEP and PEP, but we do not cover all forms of PEP. We have a list of preferred medications that we have for that, but I think the important thing from Medicaid's perspective is that we aren't seeing an issue with access for Medicaid members at the moment. Folks who want access to these medications who are Medicaid members are able to get them.
Okay, so in terms of the language that we are looking at here, how would that affect the Medicaid coverage? So it sounds like there's already coverage for both PrEP and PEP in Medicaid, but it's not all of the different possible medications. So how does this fit with DEVA?
I think some of our initial concerns that were relayed in testimony last week are still valid. I think that we are concerned about losing the ability to manage this class of drugs would have a negative impact on our supplemental rebates, our ability to capitalize on supplemental rebates. Additionally, we have a responsibility to choose the most fiscally appropriate treatment available for Medicaid members. So if there's a lower cost treatment available, that is, what we would have on our preferred drug list, which is already covered. So there's concern about unnecessary cost utilization with this language as currently written.
Is there a way that you would recommend modifying the language so that we're accomplishing the goals here for coverage and at the same time understanding that there may be differences of need out there, but also understanding the costs associated. So is there language that
so I can weigh in with a
Can you
couple of
please?
options.
Yeah.
One, I think what you had originally heard from DEVA was a request that Medicaid not be included.
Yeah.
I think there is another potential avenue in this same section of statute, which is under current law. I believe, yes, there is a requirement. So this is the rest of 4077, but for contraceptive coverage, there is a requirement. And I believe paralleling federal law that a health insurance plan provide coverage without any cost sharing for at least one drug, device, or other product within each method of contraception for women identified by the FDA and prescribed by a healthcare professional. So one option might be to require, and I think some other states do this, to require coverage without cost sharing for at least one drug in each of these categories.
I'm just wondering if Blue Cross, I know insurers have the same issue, and I want to make sure that we aren't
Right. Understood.
inadvertently causing higher prices for.
Right. Understood.
Yeah.
So, and I'm gonna go Courtney first and then over to Gail. Okay.
Thanks, Courtney Harness, Blue Cross Blue Shield of Vermont. We agree with Diva about the coverage. The only piece of this particular amendment that is of concern is the cost sharing, the co-insurance, co-payment piece. For us, our coverage is pretty robust on these drugs, as I think we testified to, and it follows most of the amendment already. The piece in this that goes beyond what we already do is the cost sharing and co-payment piece. And to Alex's point from Diva, when we get out of our area of expertise of defining drug coverage based on the most appropriate, frankly, cost for members, when we lose that ability, that language in this amendment would cost us between $100,000 and $200,000. So that would be our only recommendation. We're happy to cover at the level that we cover. We'll continue doing that. The cost sharing and co-payment work in it is upwards of $200,000 to us.
Do you have one? They said Medicaid had one option without a copay. I'm wondering. Because we also heard testimony that sometimes, and it's a very limited thing. Time frame. That sometimes people don't have.
Yeah, our coverage is very similar to Viva's in that regard, and I would say too, depending on the plan with us, if there's a wellness rider, it also bypasses the deductible. So we think the coverage is good. Just a couple of words here that make it so we can't help our members find a similar drug that will achieve the same outcome clinically at a lower cost is $150,000 to $200,000
Okay.
a year.
Which will go on to the cost.
Right. Yes.
Gail, you want to comment? You brought this to us.
Yes, thank you. Gail Zatz on behalf of the AIDS Service Organization. So this morning, Alex and I have been furiously passing language back and forth. And I think we're pretty close, if not there, related to the Medicaid piece of it, but we have not had an opportunity to discuss it yet with Blue Cross Blue Shield, but I feel very confident, famous last words, but very confident that we will arrive at.
So here's where we are at arriving. I had told Diva earlier today that we could extend our decision on 6/11 until Tuesday morning. End of conversation. So we need to have that done. And because this could drag on forever, it sounds like folks are covered and have access to medication. So, and I also started thinking about, well, we're putting 577 Array RX in place, maybe there's something there. So I'm just thinking Tuesday morning, hopefully we'll be in this room and not on the floor. And we'll be able to finish this off. So we'll hold it open till that time. Jen is not a machine. So she needs that information by Monday.
That'd be great.
So, yeah, she needs it by 2
Sure,
o'clock.
we're on that.
2 o'clock Monday afternoon. And that would help us move forward. And so Alex, are you still there?
Yes, of course. And I appreciate that, Madam Chair. And I appreciate the work that Gail and others have done to reach consensus. And I do think we can get there by Tuesday.
That's terrific. Thank you all for that. So we'll, so committee, does that feel good to you? Yeah. Yeah, we don't want to leave here with something undone, done too much. Not our usual style. So let's see where we get to. And we'll be back on Tuesday morning.
And I do just need to flag again also the state defrayal issue, and I don't know what the answer is on that. I don't know the extent to which the state would be required to defray any of the cost of adding this as a coverage requirement.
So that's a question for Diva.
Steve,
I'm sorry, that is a question for DFR, and we'd recommend having DFR speak to that again.
Sebastian, Diva, and Dave.
Okay. Okay, so we'll see what we got.
Well, even if the proposed rule doesn't go into effect, there is not currently a requirement under federal or state law for the exposure prophylaxis, and so it's already being covered on most of the plans. That there may be no actual defrayal required under the existing implementation of defrayal requirements, but I don't know how that would play out. So there need to be analysis on it.
Okay, that we just got for something. Thank you. Right, so we'll have to reach out to DFR. Okay,
Next bill.
let's move on.
582, all right. Do not have amendments for you on either of the other two bills on your agenda today. You have not done any markup that I'm aware of. So we'll start with H 582. Act relating to adult protective services. As you may recall, this bill makes some changes to the definition of neglect for adult protective services purposes.
What did we do?
When did we do it? It was 2 weeks ago.
Yeah, we went through it and we had Josh Davison, report on it, as well as Representative Noyes. And, let's remember there's some updates of it's like including practice. But why don't we just go through it, Jen, because we don't have any changes. You could do it.
Right, you have not done made any changes to it yet. So it makes changes to the definition of neglect for purposes of the chapter on adult protective services. It includes, instead of the language in there now, it means the failure of a caregiver, agent, or fiduciary to provide the goods or services that are necessary to maintain health and safety or both of a vulnerable adult. It keeps the language saying that it does not include self-neglect. And then it adds language saying that the actions or inactions of a caregiver or fiduciary shall not be considered neglect if the caregiver or fiduciary is acting pursuant to the wishes of the vulnerable adult or at the direction and authority of the vulnerable adult representative or in accordance with the terms of the vulnerable adult's advance directive. It amends the definition of report to take out the specific reference to the statements being provided to adult protective services to reflect some changes you'll see coming up later that expand the scope of where statements from a reporter may be made. In addition to or instead of adult protective services. Reporter is the person who either submitted a report to the adult protective services or to a licensing entity in accordance with the language that's coming up. Definition of representative just takes out the reference to an advance directive because it's getting its own definition down here. The new subdivision 35 has the same meaning as in the existing chapter on advanced directives. And then a fiduciary is an individual or entity with the legal responsibility to both make decisions on behalf of and for the benefit of another individual and to act in good faith and with fairness. And it includes a trustee, guardian, conservator, executor, agent, or power of attorney, or an advance directive, or representative payee. So, nursing home and residential care context.
Not yet.
Rebecca Silvernagle, Police Department.
I can't hear you.
I have some.
Okay, so we both got a problem.
I know, yeah. Department of Disabilities, Aging and Independent Living, is that better? I'll try screening. Apparently this language went through, and I guess my question is, in 36B, advanced directive, was added somewhere along the line, somewhere along the way, and all of us were kind of wondering.
Where it came from.
Yeah.
We don't know because it came to us from that.
Yeah.
So we don't know. And that actually is a question that I had about the effect of that.
Yeah, I mean, could it be?
So let's go through the bill and then let's come back to that. That's an important conversation. Okay, thank you.
Thank you.
Thanks for interrupting. That's good. It wasn't an interruption.
I'm sorry.
And please do that around the room. We're at that stage right now. The bill hasn't seemed controversial, but if there are questions that need answering, we need to find.
All right, section 2 deals with the nature and content of a report, and this report here is a report of abuse, neglect, or exploitation of a vulnerable adult. So except as otherwise provided for certain reports of neglect in subsection B, report is made to the Commissioner Commissioner for Disabilities, Aging and Independent Living or designee. And this goes into existing law about what has to be included in a report to the commissioner or designee. I don't know if you want to look at any of that that is in existing law. Just look at the new language. I'll go down to the new language. If neglect is alleged to have been perpetrated within a facility licensed by the state or a program licensed by the state, or to have been perpetrated by an individual licensed by the state, the report shall be made to the relevant licensing entity or entities as follows. What is neglect within a licensed facility or program that should be reported to the applicable state licensing unit in accordance with state and federal licensing rules and regulations. If it's neglect by an individual licensed by the Office of Professional Regulation, it would be reported to that office. And if it's neglect by an individual licensed by the Board of Medical Practice, it would be reported to that board. Then it says if a licensing entity receives a report of alleged neglect pursuant to that subdivision 1, the licensing entity shall notify Adult Protective Services that the licensing entity has received the report and is acting upon it accordingly. And if the licensing entity identifies neglect allegedly perpetrated within a licensed facility or program by a licensed individual, then the licensing entity will make a report to Adult Protective Services. So they notify Adult Protective Services if they get a report, and then if they look into it and they identify that neglect was allegedly perpetrated, then they will make a report to Adult Protective Services that kind of starts the regular ADS process.
Okay, so what would be helpful if they, the whole thing?
But we're not quite done
No,
yet.
I know.
So then under the existing statute on an assessment and investigation, under the investigation provisions, there are some timelines. This would modify some of that process. So under current law, within 30 calendar days after the date of the notice advising that a report has been substantiated, an alleged perpetrator against whom the complaint has been lodged can apply to the Human Services Board for relief on the grounds that it is unsubstantiated. That's existing law that doesn't change. But now this would require the Human Services Board to hold a fair hearing within 60 calendar days after the date of the request for a fair hearing. And it strikes out language saying, unless the commissioner agrees otherwise, the hearing will be given priority by the Human Services Board, and an expedited hearing will be provided not later than 30 calendar days after the date of the notice. The report has been substantiated and decision issued within 7 days after that. Instead, it says priority shall be given to appeals in which there are immediate employment consequences for the person appealing the decision, and the hearing officer's written findings and recommendations will be issued within 15 calendar days after.
Okay, there's a lot.
Yes. So I think there was an issue under current law with the 30 days is sort of being used for the same 30 days being used for two different purposes in a way that doesn't work. So instead, this is required 60 calendar days and 15 calendar days to issue written findings and recommendation, and the act will take effect on October 1st.
All right, so just generally, can you give us this sort of a boots on the ground overview of what this actually does? So we have a vulnerable adult.
Yes.
Could it be someone at home or in a nursing home?
In general, to fall under the Adult Protective Services statute, yes, I believe it
It
would
could
be.
be an adult at home.
It's a vulnerable adult in any
And so then
setting.
who can make the complaint about maltreatment?
In any
Person, a reporter?
person, I'm probably not I can pull up the existing statute, but I do not implement or administer this. So you may want to hear from
Or what license?
the Adult Protective Services Division or from Rebecca.
So it could be someone.
I mean, I can pull up the statute, but it's a chapter.
So, okay, so we're saying that someone can make a complaint,
Right, this is existing law.
right?
Um, So I will put up the language on reporting. The state statute. So all employees, contracted volunteers or grantees who directly provide healthcare, law enforcement, caregiving, counseling, education, or social services to adults who know this is mandated reporting. Who know of information of abuse, neglect, or exploitation of a vulnerable adult, or have reason to suspect that any vulnerable adult has been abused, neglected, or exploited. So,
Who did this?
The other 16.
Mine is
Welcome
not
again.
gonna be Jack. Okay, Fletcher.
so they're mandated reporters. And then any other concerned person not listed who knows or has received a report of complaint or has reason to suspect may report or cause the report to be made. So there are certain mandated reporters and any other concerned person may make a report.
I wanted to make sure we're all,
Thank you, I agree.
okay,
But something's triggered this, obviously something out in the field has gone awry and.
I'm trying to, yeah, what's the problem?
right, so
I think what we're
I
all.
guess it's towards the end, this is with the timeline, it says like.
Have you heard from, yes, have you heard from the department on this? It would be helpful to hear.
thank you for this.
You're very welcome. So why are we here? What problem are we trying to solve? When we revisited the statute, a couple years ago, the definition of neglect fell short of the federal regulations. They wanted to see basically what it says a year now. And so we wanted to fix that to make it compliant. The rest of it is a process to make that happen. So these folks here that we'll have some friends here.
Yeah, this,
For the
Helen,
record,
for the record, Helen Laban from the Vermont Healthcare Association. We represent nursing homes, assisted living and residential care homes. So there's a two-part issue here. One is that we needed to update the definition of neglect to match the federal definition, and we need to do that by October 1st. And there are penalties attached. We do not. So you see a change to the neglect definition here. In changing to match the federal definition, though, it created some overlap for those who are regulating facilities like nursing homes. It creates some overlap with items that we already had under our regulatory structure for reporting. So we needed additional language in the statute to explain how these reports were now going to be redirected because of that underlying federal definitional change.
That makes sense.
Does that make sense?
Yeah, good. I just lost it for a minute.
okay. No, we did hear it was to come in compliance with federal law, but this is very,
Yeah.
the rest of it is how.
Yeah.
Right.
And Jessica Barnard with the Vermont Medical Society. If I may just add, there was a thank you to many people, a very big stakeholder process, kind of looking at all of the impacts of this change of definition over the summer and fall, many meetings. And that's where and there was also discussion of this definition of fiduciary. So just like circling back to that piece, a lot of input and discussion around updating that definition, and agreement at the time of all of those parties was that the agent under a power of attorney is a typical use of the term fiduciary, but not an agent under an advance directive. And so I believe the language that APS submitted for drafting, which was a result of all that stakeholder meetings, had that stricken. So I think none of us are actually entirely clear why. And this was actually did not get added in the House. This was as introduced. So we're just.
It's entirely possible it was me.
Well, not judging. And in fact, on our part, we completely missed it on the House side. It was there as well, and it didn't even like jump out as a change. So just. That's
Advanced directive.
the or advanced directive. We recommended removing.
Yeah.
Where, can you orient me where?
Yes, it's on.
Page 3, line 16.
Yeah, or so for 36 feet.
What are so we have fiduciary listed here.
Yeah.
A trustee, a guardian, conservator, an executor.
Executive. The emphasis is important.
Pretty good.
There would be an APS call for that.
We could add the operator of a guillotine. if that-
Agents under the power of attorney. So. Ignoring what I just said earlier. Okay, so. What are the implications? Because when I saw that, I said, that's not a person, that's an advanced directive. And it's got a lot of elements to it. So what are the implications of having an advanced directive in there?
So right now it's referring to an agent under an advanced directive in addition to an agent under a power of attorney. And I think that what you're hearing, because there's language earlier in the bill that talks about a fiduciary having a responsibility, and that's generally around financial matters. I think so. I think that if I understand the point here is that fiduciary doesn't generally include healthcare decisions, and so it's confusing to introduce the concept of an agent under an advanced directive here when we're really talking about
So it could be a,
financial fiduciary.
could be a daughter, son.
If they
or a friend,
are,
or-
yes, it's somebody with legal responsibility to make. Let me back up. Somebody with legal responsibility to make.
What are the implications of adding this in? And I'm looking at a Dale and also at VMS and all. At the nursing home. I'm looking at you folks.
Well, I mean, they're two separate types of documents, right? So, it doesn't need to be here. We've already got it somewhere else, but.
It is an incorrect definition of advanced directive. That's our primary problem with it, that it just was a straight up error that an advanced directive does not give anyone fiduciary responsibility.
Right, that's not,
Okay.
Because I'm,
more of a medical thing rather than.
it is a medical thing.
Right, and I think the way the language is, I mean, I think I probably did add it, and I think because of the way the language is written does not specify financial, it just talks about making decisions on behalf of and for the benefit of another individual and acting in good faith and with fairness. But I think the point of the use of the term here is not in a healthcare decision-making context.
Yeah.
Although a representative up here can be an agent under an advanced directive.
You could have full pieces of paper.
We could have one.
You could have both the power of attorney and an advanced directive.
Yeah, they cover two different things. One of them is proper estate planning. Sure.
I've heard
Old estate planning.
if I have an advanced directive that says, I want you to withhold food and water. Because I've got cancer and I'm ready to die. My representative, my fiduciary in there might be my daughter, my husband, but it's somebody,
Your agent.
my agent. Other members of my family might not like that decision. I've been told that families can come in, they can get court, that puts hospitals, that was the only place I could see saying, if I put my advanced directives, I don't want food and water, and I'm at home, I'm 100 years old and I'm sick and I'm not gonna eat anymore. I was seeing this could say you couldn't go to court and charge.
I think there,
my
I don't want to.
agent.
I don't think,
That's,
I don't think
maybe
we're.
that's why this.
There's a chapter on
So,
advanced
Yeah,
directives.
Yeah,
That's all about how, the
yeah, okay, that was the only way I could see this.
So Jessica Barnard with the Medical Society, I do think it's important to point out, though, for this discussion, there is language on page 2, sections C, sort of lines 10 through 16, where it's saying what does not include neglect or what is not defined as neglect, and that includes acting in accordance with the Vulnerable Adults Advanced Directive. So if the person said, please withhold do not give me food or
Right.
water in accordance with this, and you are acting in accordance with that, then that would not be neglect, even if typically an older adults in your care with food and water from them could be considered.
Yes.
neglect. So I just want,
So
there is that overlap with advanced.
so on line 15. in
Line
accordance
15
with
and 15.
Terms of vulnerable adults
Right.
advanced direct.
Correct.
And again, people are tied in both as the caregiver and in the fiduciary. So I think a lot of these examples is more focused on the caregiver component. The fiduciary would have responsibility over other elements of the estate not connected to that
Yeah.
delivery of care.
Yeah.
So in the end, are we striking advanced directive on line 16?
Yes.
Okay. All right. Got it.
That's what I'm hearing.
Is that the
All
only,
agreed, so they're out voting.
Yeah.
is that the only change?
Well, so, okay, so what
That's
is
the only
that?
change you have been asked to make so far.
Right.
So we're striking that on page 3.
Yes.
That's
That's it.
different. Now, we are not striking it.
On page
Then
2.
do we need the definition
You do.
Yes.
Okay.
Because if you look above
Because
it, the
of the
definition of
previous-
representative,
section?
right, that currently ties it to an advanced directive
Understood.
executed.
Yeah, all right. So is that the biggest? I do have another question. That's more of a general question. It's one we always concern ourselves with when we see this. How do we preclude frivolous complaints?
Mhm.
I mean, honestly, I can have someone come in and we get that a lot in this building. So,
Joseph Barnard with the Medical Society, and there was a lot of discussion again among all these folks about the volume of complaints, where they go, and I would say that was one of the reasonings behind sort of where some of the complaints are directed. So for example, for licensed individuals or entities, they will go to their licensing entity or agency so that those, and I'll just give the example of my members who are licensed by the Board of Medical Practice, where that entity has experience comparing to what other professionals would do in that situation. Did this really violate the standard of care? Was this abuse given the totality of the circumstances? They would weigh all of that. But I think there was also consensus there should be sort of no wrong door. It's important that complaints at least get submitted and reviewed. And then there's an entity tasked with sorting out, was this just a frivolous complaint or was there merit to it?
and then I have a question for Dale regarding the number of complaints that are being resolved at the Human Services Board. Are you sensing that this is something that's escalated over time? Or is it,
I'll have to get back to you on that.
yeah, no, I mean, that's just a information.
Overall, I mean, it's been
So it goes, I didn't even know that.
Yeah.
So a complaint goes to a human service.
That was that was the piece that we were looking at. There's a change in the bill that about the timing, but that's if somebody is challenging a finding that they,
From 30
Yeah.
to 60.
right, that piece of it. That's for somebody to appeal the finding, the department's finding that they did admit abuse, neglect, or.
It actually goes to human.
Right, that's the fair hearing.
Okay.
Thank you. It's in statute.
So committee questions, further questions. Sounds like we've fixed the concern we've heard about. And committee, I don't know that we need to spend more time on this bill.
So Madam Chair, I will note one more thing, which is
Uh-oh.
that, no, that's okay, not in the bill, just, there is an annual Adult Protective Services report that gets submitted to the legislature. I just opened up the latest one, and it does include information on the number of appeals and recommendations of substantiation that concluded with the Human Services Board, including various information and comparisons with the 2 prior fiscal years.
So we're good on that.
So,
Yeah,
yes.
Okay.
Thank you.
Good. But take that off your list.
Yeah.
Okay, that's good. All right, committee, so Jen, with that one amendment that we've made, that we took out, board advanced directive. And we got anything else?
That's all
Haven't
I
changed today.
heard.
Is there any interest in?
I'll make the motion.
I haven't even drafted the amendment yet, so.
Oh.
Yeah, so we can't do it yet.
Can we speak slowly? I'm gonna.
Oh.
Will this be draft 2.1, Jen?
No, it'll be 1.1, because it's the only
1.1.
amendment. It's because it's just gonna be
Does
one.
it have to be a
it's just
strike?
It's not gonna be
Got
a
it.
strike.
Yeah.
Draft 1.1.
And
I
it's,
make a
so wait, I need to understand this, Senator. So we're gonna have a simple little amendment.
Yes, but I'm gonna draft right now and put up
Gonna
one
draft,
for
it's gonna strike or an advanced directive,
In the draft
Yeah.
we today, right now.
and then
Draft update.
I'll say it when I say my motion.
what are you,
I'll say the date, I'll say the time, everything.
is it time for the motion, Senator? Go ahead. I think so.
I make a motion to vote favorably on committee H582 draft 1.1.
As amended, an amendment,
An
amendment.
Favorable with amendment.
an amendment to
amendment.
H 580.
Oh, we're doing the two vote thing here again.
Wow.
Yeah, we have to vote to amend.
All right, that's what I'm saying.
So you vote to amend, so I vote to amend 582 draft 1.1 on April 23rd at 11:39 a.m.
So is that your motion?
That is my motion.
Okay. All right, discussion. No robust discussion? Okay,
Without the amendment,
on the amendment,
okay,
On the
we're voting on taking out or advanced direct.
or advanced directive.
So Senator,
Sure. Senator Benson.
Yes.
Senator Cummings. Senator Gulick.
Yes.
Senator Morley, yes. Senator Lyons.
yes,
Now I'll move.
So just to make sure you're happy with it,
Okay.
here's what I just did. I will send it for editing just to make sure I haven't made any errors, but this just says you recommend that the Senate propose to the House that the bill be amended in section 1 and subdivision 36B following power of attorney by striking out or an advanced directive.
okay,
We good?
that worked.
To me, I was making sure there was another words in this, so. Okay. So I'll move that we pass the amended version now of H 582 out of committee. It is draft 1.1 and same date, same time, pretty much. So,
It is. Yes, not same time, but that's all right.
I mean, I said pretty much. Well, 2 minutes later, 11:41.
All right, Senator Benson.
Yes.
Senator Cummings.
Yes.
Senator Gulick.
Yes.
Senator Morley, yes. Senator Lyons.
Yes,
5-0-0.
who would like to report this? I know it's gonna be difficult, it's a long amendment.
I'll do it.
All right, Senator Benson, thank you. It's actually a very good bill and it's very important. And it's something we've worked on before. And we keep resolving all of the problems. Nice. Vulnerable adults need whatever help we can give them.
Yeah.
All right.
Neurological rights.
Yes.
Just a second.
Oh, that's it. Got a lot of coffee today. Like sugar, butter, sugar, and flour. Now,
Thank you for the thought drop.
Sherry, do you want to take more?
I've got something.
thanks for wearing such a happy brooch.
All right, so we're gonna move on to H 814. And we have spent some time on this one. This is the one that Representative Chino came in and talked about HIPAA regulations and certain parts. Talking about AI decision making, not human, and guardrails. But this is basically what general logical rights.
So this one up as well. Or clean, enacted neurological rights and the use of artificial intelligence technology and human services. starts out with the intent language. Around the use of AI and protections. And section 2 is a chapter, really just a section, a chapter on individual rights with respect to neurological rights, mental and neural data privacy, freedom of thought. There's section 3 amends the AI Advisory Council, changes some of the appointing authorities, adds a couple of members with experience in healthcare.
So this is, there are some
Treasurer,
other new members being added here.
there are.
But remember, that was one of the important things that the bill was.
Right.
Yeah.
So, yeah, so it changes the appointing authority for a couple of them and it adds a new member with experience in healthcare, new member with experience in public education and the state treasurer, and then keeps the governor's appointment, but broadens the scope. It extends the lifetime of the AI Advisory Council till June 30th, 2030. And it directs the AI Advisory Council and others to review certain information about the use of artificial intelligence, research existing and potential uses of it, and create opportunities for public engagement, education and engagement and development of AI policy, and to report back in January to the General Assembly with statutory changes, and including protections for neurological rights, protections related to neurotechnologies, and proposed definitions for relevant terminology, guidance on the use of generative AI by regulated professions, and the use of artificial and augmented intelligence in health insurance utilization review processes. Summarizing ways government can promote ethical and responsible use of AI technology, pros and pilot projects, and improve public engagement in public finance using AI, and identifying any reasons for further delaying or removing the new 2030 sunset on the advisory council.
So I understand. We've had that discussion about generative artificial intelligence and a definition somewhere, but I think
I think you have a definition that you're working on in the bill, Katie, in 816.
yeah, yes, we do. So I'm not gonna touch it here. Then my other question, I think, is what discussion, if any, has happened about ethics? Because part of it is the ethical use of artificial intelligence. And there are not members on this.
Well, there's actually, under existing law, one member with experience in the field of ethics and human rights appointed by the governor, and this changes that to appointed by the National Association of Social Workers, Manchester.
Okay, so are we understanding that the National Association of Social Workers are experts in this area?
I believe that was something Representative Sheena had talked to you about.
You did. I'm fine
I did
with
not.
that. I just want to be sure we have ethics covered. Okay. Are there any questions?
So there's currently 10 people on the advisory council. Jen. I just looked it up, so I
Okay.
counted 10.
And yes, if you looked up and counted, yes.
And we're adding 3. No, 4.
These were out. I think just 4 new ones.
So there's a total of 14
Education.
So to do the letters. Yes, 14, because we go through N. And there's nobody that
so they
really
can have a time.
Okay.
Okay,
So the new members are the member with experience in healthcare appointed by the Medical Society, member with expertise in public education appointed by the treasurer, and the broad gubernatorial appointee.
Okay, and we're changing the commissioner of health to the secretary of human services.
Right.
Okay, great.
are you good with that?
Sounds good, yeah. Okay.
Okay. I think so. Who wants to do it?
Oh, Well, we haven't voted on it yet.
I said, who wants to make a
I want to
motion?
make, I made a bunch of motions.
It's somebody else's turn to make a motion.
Someone else's turn. I will move. We approve
814.
814,
It's passed by the House.
as passed by the House. Okay, that's what I'm looking for, is a draft.
Yeah.
Okay, I will move that as it was.
Discussion. Okay,
All right. Senator Benson.
Yes.
That's not quite right.
This whole AI.
I
feel
know.
the same way.
It's gonna drive us all nuts.
Senator Cummings.
Yes,
Senator Gulick, yes.
I am a yes.
enthusiastic, yes.
Senator Morley, kind of feeling like Senator Benson does, yes. Senator Lyons.
Yes. Now, who would like to report this? Huh,
That's what I think.
I'm looking all around the table.
I have a
Senator,
few little things on the agenda.
no, I know where the enthusiasm
Yeah,
is here.
that's a big, it's a good, like, that, like, innovation report.
It's trying.
Oh, wow.
So it's you?
Yeah. Unfinished miscellaneous budget.
So it's you.
Yes.
It's me.
Trying to guess. Okay, say, listen. Thank you for your good work. We've got heavy lifting ahead of us, especially on 938. We'll keep going through it. Please read it. And everything else that you have. We've got a bunch of bills next week. And remember that on the 28th, we have the cancer fair coming.
Right.
That's gonna be fun. Cancer Center.